But our next two speakers remind us of Pope Paul VI's call to doctors and nurses. And I quote him, "We hold in the highest esteem those doctors and members of the nursing profession who in the exercise of their calling endeavor to fulfill the demands of their Christian vocation before any merely human interest. Let them strive to win agreement and support for these policies among their professional colleagues." There is nothing like a well-educated Catholic physician on natural family planning, science and methodology, and church teaching to be true evangelizers in their field. And so once more, I'm honored to introduce Dr. Kathleen Raviele. Dr. Raviele, I've got a long description here, but I know the time is ticking. But do know that she is a consultant for the Marquette NFP Institute, and she has her own active practice in OBGYN and NFP only practice.
Thank you, Teresa.
Yeah.
Thank you, Teresa, for inviting me, and I want to particularly thank the bishops and the priests and the religious who are here. Because I want to share with you that you really can have a profound influence on the physicians, nurses, PAs that you come in contact with, and I'll talk about that a little bit at the end. In this talk, I'd like to answer two questions. Can a woman get good or excellent health care following the principles in Humanae vitae, number one? And can a physician deliver good and excellent health care following the provisions of Humanae vitae? Now, imagine if you went to your internist with high blood pressure, diabetes, perhaps chest pains, and the answer was one medication, one treatment for that. I mean, what would you think about the doctor in that case? You'd think he wasn't really working you up. So when a woman goes into the gynecologist's office or family practice doctor with acne, too many periods, too few periods, cramps with her period, even infertility issues, headaches, even migraine headaches, or PMS, what is the answer? Well, even if she's a young girl, she may have just started her period, 11 or 12 years old. She may be a mature woman, or she may be a woman who's in the perimenopause. I had to get some of my grandchildren into this presentation. The answer is always the same, the birth control pill. And so if you're an NFP-only OBGYN, even if the woman is coming to you not necessarily because she wants to learn NFP, your practice will be full of women who say, I don't want to be on the pill. I want you to find out what's wrong with me and treat it. Because we have a better answer. Charting, one of the methods of fertility awareness, can aid in the diagnosis and treatment of several female gynecologic disorders. And as the previous speakers said, it can assist couples in living with their fertility without using chemicals or barriers throughout their reproductive life. Now, 5 years ago, when a patient would come in my office and I'd ask her what was the first day of her last menstrual period, 35% of the time they couldn't tell me, especially if they were a longer distance from the last period. But now, everybody pulls out their phone. And even if they're not doing NFP, they are charting their cycles on their phone. Now that actually gives me a lot of hope for the future. Women are paying attention to their periods. Charting NFP on paper, phones, or tablets provides very valuable clues to the doctor on what's going on. It tells you the pattern of their bleeding, which helps figure out what the cause of any abnormal bleeding is. It identifies, if they're using an ovulation chart, whether or not they're ovulating. But young couples today are rapidly abandoning paper charts and rapidly abandoning classes in person to do online charting, online classes, and relying on apps on their phone to chart NFP. There are hundreds of apps now to chart your cycles. There are 2 apps so far that were actually developed by NFP programs. The Go one is for couple-to-couple league symptothermal program, And the one on the right is for the Marquette program, which actually tells you when you're fertile and when you're not fertile. So what are the medical applications of NFP? I have a lot more in my paper. Teresa asked me to keep it simple, so I'm going to try to keep it very simple. I'm going to talk about how does NFP help you to diagnose and treat dysfunctional uterine bleeding situations. Polycystic ovary syndrome. When I'm talking to marriage prep groups, I always address this at the end of the talk because a lot of the women I can tell looking around are on birth control pills because of polycystic ovary syndrome, endometriosis, and infertility and subfertility. Dysfunctional uterine bleeding is defined as periods that are too long, periods that are too heavy, or women who are bleeding outside of the normal period. Periods go 3 to 7 days. If women are bleeding longer than that, that's abnormal. If they're changing a pad or a tampon more often than every 2 hours, that's abnormal. And if they're bleeding other times in their cycle, that is not normal. So you have to work them up. Now, the first thing you want to make sure is that she's not pregnant. And this is a beautiful ultrasound of a 13-week baby. And you see the head here, and the nose, and the mouth, the chest, the spine. And even if the woman comes in and said, oh, I had my tubes tied years ago, there's no way I could be pregnant. I've heard that before. You want to make sure they're not pregnant. You also want to make sure they don't have a cancer. You want to make sure they don't have an infection in the uterus. You want to check them for a hormonal abnormality. Look for a structural abnormality in the uterus, either fibroids, polyps, or adenomyosis, which is a type of endometriosis in the wall of the uterus. You want to look for a foreign body. Check them for a coagulation defect if they have extremely heavy periods. And have they taken hormones? Unless you ask, you may not realize this girl is taking emergency contraception periodically and having abnormal bleeding with it. So you work them up. The history is so important, and unfortunately today with electronic records, the push for doctors to see a certain number of patients, oftentimes the history is gone over very superficially. You want to take a detailed history, you want to do a pelvic exam and do a pap smear, check her complete blood count and platelet count, do a pregnancy test, check her thyroid, do a carefully timed progesterone level when she should be ovulating. If she's an older woman, you want to do an endometrial biopsy to rule out cancer and get an ultrasound and a sonohysterogram if it's indicated. So here's an example of an actual patient with unusual bleeding. I have Marquette charts because that's the program I'm primarily involved with, but I want to stress that any of these principles can be applied to any of the methods of NFP. I have patients who come in with charts, some of the charts they just got online, or they're from Couple to Couple League or Northwest or Creighton, and as long as they're charting consistently, you can apply the same principles to all their charts. So anyway, this woman has a period that goes on for 5 days. I'm sorry, this isn't working. Then she has 3 days, day 6 through 8, where she doesn't see any bleeding. On day 9, it's red again because she has spotting. She starts into her mucus cycle, which is what the blue is here. And then she is having another day of spotting on day 14, ovulates by mucus on day 16. She's also using the fertility monitor, the clear blue monitor. She's ovulating on day 16 with the monitor also. She has a normal post-ovulatory phase, so you can already surmise that her progesterone level is probably fine. So what is the cause of her bleeding? This patient wasn't even aware that she had been having bleeding until she started NFP, and then the bleeding became more and more prominent, and she had an endometrial polyp in the uterus. So she went to D&C and hysteroscopy and had polyp, actually more than one polyp, and they were removed, and that took care of her bleeding. Fibroids, I live in the South. We have a high African American population. I would say most women get in their late 30s, early 40s have fibroids. This would be the normal uterus here, but all these other muscular growths here are fibroids. They're a common cause of abnormal bleeding and can be a cause of infertility. So what is the ethical treatment for dysfunctional uterine bleeding? Well, first of all, you want to check a blood count and restore their blood count. I had a patient drive herself to the office one day with a hemoglobin of 3.5. and the normal hemoglobin is 12, so she went by ambulance to the hospital to get a blood transfusion. So you restore the blood count by giving iron, sometimes having to transfuse them. There are 3 different medications that are non-hormonal that can decrease bleeding with a period. And I say most general OBGYNs don't even try these on patients, they just put them on birth control pills. 2 of them are non-steroidal anti-inflammatories. One of them is called meclofenamate sodium, this is in the paper, and the other one is mefenamic acid, which used to be called Ponstel. Then there was a drug specifically developed for heavy bleeding called Listida, or tranexamic acid, and it prevents the breakdown of clots in the uterus during the period. All 3 of these drugs decrease bleeding by about 50%. So you may be able to save somebody from a hysterectomy by giving her this medication on the heavy days of her period each month. Also, if they have a hormonal problem, you want to give them cooperative progesterone therapy, so you're giving them progesterone after ovulation in the second half of the cycle to prime the uterus for a normal period. If they have an infection, you treat them with antibiotics, or even if you are suspecting an infection, you treat them with antibiotics. And if necessary, you go on to a D&C and hysteroscopy, or if they have fibroids, you remove the fibroids, or they may even have to have a hysterectomy. What are the unethical treatments for dysfunctional uterine bleeding? Well, women are commonly being encouraged to have what's called an endometrial ablation. Part of this is actually, I found out that OBGYNs get paid almost as much for an endometrial ablation as they do for a hysterectomy. And they can do it in a very short period of time with no big follow-up. However, if you destroy the lining of the uterus and the woman is still capable of getting pregnant, you have set her up for either a disastrous pregnancy or repeated miscarriages. So in the mainstream OBGYN field, you're supposed to do a tubal ligation at the time you do an endometrial ablation. Well, we can't do that. So the only time that you would do it ethically would be if the woman had already been sterilized, so you know she can't get pregnant, or if the woman is in a situation, perhaps a religious sister, who is not sexually active. Also, it's encouraged to have intrauterine devices, progesterone-containing intrauterine devices to reduce bleeding. Intrauterine devices do not prevent ovulation. So again, you're going to have the same circumstance where the woman may ovulate. The IUD is causing hormonal changes with the lining of the uterus that would prevent implantation or causing a chronic inflammation, preventing implantation, so that would not be used. And often this is an excuse for putting women on birth control pills indefinitely, but there are other treatments. The next condition I want to talk about is polycystic ovary syndrome. Most NFP OBGYNs have many, many patients in their practices with PCOS. It occurs in 7% of women. So there are about 3 million women in the United States with PCOS. There are short-term problems with PCOS. 70% of them are overweight. They may have acne or increased facial or body hair. They have irregular periods, and that drives women crazy not to have a regular period. And it's associated with infertility. The long-term effects are, though, these women are at increased risk for endometrial cancer and breast cancer because they have high levels of estrogen on a chronic basis. They're also at increased risk for diabetes, and often these women have a family history of diabetes. They're at increased risk for high blood pressure and also high cholesterol. Well, a consensus group in 2003 met on trying to define what constitutes polycystic ovary syndrome, and actually they simplified things. I love simple. They broke it down into 3 different criteria, and the woman only had to have 2 out of the 3. So either clinically she had signs of increased testosterone with acne, increased facial hair, or she may not have those, but she has high testosterone by lab test. She ovulates irregularly, usually defined as fewer than 8 periods a year, or she has polycystic ovaries by ultrasound. She has to have 2 of those 3 criteria. This is an NFP chart of a woman with PCOS who was not heavy, But you see how women with PCOS, when they're doing NFP to avoid pregnancy, this is one of the major areas I think we need to do more research in, because these patients typically have long mucus cycles with long periods of abstinence. By mucus, this woman's ovulating on day 21, but by the monitor, she isn't ovulating over here. So the observations can be extremely confusing. So this couple, these are the days of intercourse, are having long periods of abstinence because they have a serious reason to avoid pregnancy. This is an ultrasound picture of a polycystic ovary. This is the ovary here, and you see lots of follicles that have not ruptured, and that is the characteristic of polycystic ovary syndrome. Insulin resistance occurs in about anywhere from 30 to 70% of these women with PCOS. So instead of choosing the healthy foods on the left, vegetables and fish and low-fat meats, they want cake and ice cream and milkshakes and soft drinks. And so these carbohydrate cravings lead to obesity because they have high insulin levels, which acts as a growth hormone, and 25% of these women ultimately go on to develop diabetes. Sometimes when you're working them up, you find they have diabetes at that point. The long anovulatory cycles lead to infertility, and the high cholesterol levels lead to heart disease. So I've seen so many patients over the years who have come in and said, I went into the doctor and I said I had this, this, and this, and they said, oh, you have PCOS, we'll start you on the pill. Didn't have any kind of an evaluation. But you do want to evaluate these women. You want to get a total and free testosterone on them with DHEAS to make sure they don't have an adrenal source of the testosterone. I've only had one patient in 30 years that had that. You want to check their thyroid. You check for prolactin, which is a pituitary hormone that can also cause irregular cycles. You do a fasting blood sugar and a hemoglobin A1C to make sure they're not already diabetic. Get an ultrasound of their ovaries. And you may want to get a fasting 17-alpha hydroxyprogesterone to make sure there is not a adrenal problem going on. Now, something as physicians we sometimes forget because everybody hastily goes to prescribing medications for conditions. These women respond very well to lifestyle changes. And I tell them, I know this is hard, but this is going to be a lifelong problem for you. You need to do this. They need to go on a low carbohydrate diet, whatever one you want to pick. You know, the South Beach diet, the 17-day diet, the paleo diet, the whole food diet, whatever you want to do, it needs to be low carbohydrate. I tell them you need to stop eating things out of a box, start cooking your own food, and watching your portion sizes. The Harvard fertility study also showed that low-fat dairy was probably contributing to PCOS in this country. There was a quite complicated explanation for that. So I tell them to come off low-fat dairy. Characteristically, they are craving dairy and eating a lot of dairy. Tell them to stop sugar. I tell them it's their enemy. And stop refined carbohydrates, white rice, white bread, white pasta. And to achieve at least a 5% weight reduction. That may help them with their cycles. And these women also need to exercise. Lots of times it's not obvious these girls have PCOS in their teenage years because they're playing soccer and they're on the swim team and they're really exercising and they're keeping their weight down, and they go off to college, and instead of gaining the freshman 5, they gain the freshman 20, and pretty soon their cycles are all messed up. So what's the ethical treatment of PCOS? Actually, birth control pills makes the insulin resistance worse. So birth control pills, I tell patients, is not a good treatment for your condition. You want to give her a normal period. This bothers women. They want to have a period every month. So you want to cycle them on progesterone. If they have long cycles, you just pick a day and start them on progesterone. So anywhere from day 16 to 19 of their cycle for 10 days, they'll get a period. In response to that, if you do see that they are ovulating, they can start the progesterone on peak +3, and we give them anywhere from 200 to 400 milligrams of progesterone, which is available by prescription at the pharmacy. Prometrium is the original name, to give them a regular period. Also, they have found that inositol plays a role in the disruption that's going on with glucose metabolism in the ovary. I mean, it's quite complicated. And so, at least for the past 10 years, the reproductive endocrinologists have recommended a combination inositol product. And because we don't have CMEs, I can give you the name of one. It's Ovasitol, Ovasitol. It's made by Theralogics. It's a powder they take twice a day. And that helps also with restoring normal ovarian function. It's over the counter. They can buy it online. Also, if they're insulin resistant, you want to put them on metformin. Metformin's a very safe drug. It helps regulate their blood sugars without causing low blood sugars. It helps them then to be able to control their appetite, lowers their insulin levels, helps with weight loss, and with that, hopefully restoring regular periods. Increased facial hair can be treated with a water pill, a diuretic spironolactone. And so most women do very well with that. But PCOS is associated with infertility. The good thing is that these women usually can be treated with a drug such as Clomid, clomiphene citrate, which has been around for 60 years. It's a very safe, kind of an anti-estrogen. I tell patients it fools your pituitary gland and think you don't have enough estrogen, so then your pituitary gland starts putting out FSH and LH to get you to ovulate. So 80% of women with PCOS will ovulate with Clomid. Doesn't require a lot of monitoring. General OBGYN can do this without any problem. And 50% will conceive by 6 cycles if they do not have other conditions. If Clomid fails, then you go on to the injectables. Personally, I don't do that in my practice because it requires a lot of monitoring, so I send them to the reproductive endocrinologist, one who is not doing in vitro, as a matter of fact, with the caveat to the patient on what they can do and cannot do. Or you have to go in and decrease the number of unruptured follicles in the ovaries. What's popular now is ovarian drilling. In the literature, it says wedge resections are no longer done, but there are NFP doctors who are still doing wedge resections by robotic surgery. I would encourage them to publish studies on it, because in the main literature, they say that this shouldn't be done anymore. And even going on the metformin may help with the woman's ovulation. These women also have a higher miscarriage rate, so you need to monitor them, have them come right in as soon as they get pregnant to make sure their hormone levels are okay. The next condition we're going to talk about is endometriosis. This occurs in 10% of women. It's a common cause of pelvic pain. You have a 7 times increased risk of having endometriosis if you have another family member with it. And so there's sometimes a lag of 8 to 12 years before it's diagnosed. It's a cause of infertility in 38% of women who have infertility. And this is a laparoscopic view of endometriosis. This woman has a powder burn lesion right here on the peritoneum and the cul-de-sac. Sometimes women with relatively minor lesions have terrible pain, and other women with terrible endometriosis have minimal pain. So we treat them with anti-inflammatories. If you know they have endometriosis, they may need to go on an anti-estrogen Depolupron for 6 months, may give pain relief for 2 years, does not help with conception. This is one situation where I do have 2 patients in my practice on oral contraceptives. They're taking them continuously. They're not sexually active, but they have to have relief from their pain. Depo-medroxyprogesterone can also, Depo-Provera can be used to treat it, but this causes a lot of messed up cycles. At least women don't ovulate on medroxyprogesterone Depo. One thing I want to mention that isn't really talked about much is there have been several studies published, including the US, on using vaginal danazol. Danazol is one of the original anti-estrogen medications. If you have it compounded in a 200 milligram capsule, the patient can use it vaginally for up to 12 months. It doesn't change their cycles, and by ultrasound and by laparoscopy, it reduces the size of the lesions, and so you may get some pain relief. Sometimes patients, even after a complete hysterectomy, still have pain, and this is ideal in that situation. But ultimately, these women have to have surgery. We need to remove or destroy the endometriosis completely with an experienced endometriosis surgeon. We have 2 centers in Atlanta that do this very, very well. They have an endometrioma in the ovary, you remove it. Doing a presacral neurectomy, cutting the nerves and the uterosacral ligaments also may help with central pain. And this is the only way a patient experiencing infertility due to endometriosis is going to be able to get pregnant. The other medications, the other treatments are not going to help. Lastly, I want to talk about NFP and infertility. The NFP charting is totally valuable. You want to work up all the compartments. I want to mention something about semen analysis. We don't do semen analyses like everybody else does. We give the couple a special sheath with holes poked in the end of it. They have normal intercourse, take the secretions to the lab immediately afterwards to identify if the husband has a problem. We want to pinpoint the day of ovulation. The more data you have, the better. And this is an example of a chart where the woman is charting temperature, she's charting mucus, she's charting the monitor. The only sign that is showing that she is ovulating is the temperature. So the more data you have, the better. In treatment, you want to follow the 3 fundamental goods in Donum Vitae: respect the right to life, and the physical integrity of every human being from conception to natural death, the baby. You want to respect the unity of marriage, which means reciprocal respect for the right within the marriage to become a father or mother only together with the other spouse, and the specifically human values of sexuality, which require that the procreation of a human person must come about through the fruit of the conjugal act specific to the love of the couple. So we restore normal anatomy, we restore normal hormones so that the couple can engage in conjugal acts resulting in procreation without the physician's actions directly interfering in that act itself. And then ultimately, if they're not able to get pregnant, discuss adoption. The immoral treatments are all the assisted reproductive technologies, which includes intrauterine insemination, either with the husband's semen or a donor, in vitro fertilization, freezing of embryos, sperm, eggs, injecting one sperm into the egg, the height of arrogance. When a couple has relations, 20 million sperm get deposited, but the scientist is choosing one sperm to drive into the egg. Doing pre-implantation diagnosis, looking for an abnormality, or after conceiving 3 or 4 babies with in vitro, terminating some of them. So the only situation where you definitely would have to use birth control pills is in a patient who carries the BRCA1 or BRCA2 mutation for breast cancer and ovarian cancer. Women with BRCA1, BRCA2 have a 45 to 85% risk of getting, the risk of ovarian cancer in BRCA1 is 39 to 46% by age 70. In BRCA2, it's 10 to 27% by age 70. They have a 45 to 85% chance of getting breast cancer. The general population risk of ovarian cancer is 1.4%. The good thing is it only takes 1 year of birth control pills to reduce these women's chances of getting ovarian cancer. And that's important because sometimes these women are put on pills indefinitely. They should be encouraged to have children, and then in their late 30s or at 40, they need to have their tubes and ovaries removed. And I want to just finish. The Catholic Medical Association published a book called The Catholic Witness in Healthcare through Catholic University of America that talks about our view of ethical practices in medicine, and it has been available at this meeting, and so I would encourage you to buy it and encourage lay people to read it also. Thank you very much.